obtained from these machines are not interchangeable, and that's why we have 3 speakers for 3 different machines. So I'm going to go over what we're imaging, what is considered clinically significant, and then lastly, the big picture. So what are we imaging in the current Spectralis software? We're of course looking at the nerve fiber layer, the optic nerve, and the macula. For the nerve fiber layer thickness scans, we know that this is the most commonly used scan, and in the Spectralis it winds up being a 3.45 millimeter diameter circle for a typical axial length. And as I mentioned before, there is tracking capabilities, meaning you can choose a baseline scan, and then all follow-up scans are then aligned exactly to scan the same area as the baseline scan. In the Glaucoma Module Premium Edition in 2016, software upgrade enables us now to have 3 diameters for nerve fiber layer thickness, 3.5, 4.1, and 4.65. However, recent studies suggest that 3.5 may still be the best size. Due to Joel Schumann's research has not changed much. So second scan is the optic nerve scan. The software enables to calculate or quantify neural retinal rim tissue with a BMO minimum rim width. Now this is a paradigm shift over the other neural retinal rim parameters because in the old way we use a reference plane. So meaning with the reference plane, as you can see in the blue arrow, everything above it is the neural retinal rim in red. However, as you can see on the lower right, this is my colleague Johannes de Boer's eye, and he's a PhD physics person. And he said, you know, Teresa, there's some inherent intrinsic inaccuracies in trying to find a flat reference plane that is most parallel to the back of the RPE or the back of the eye, which is a sphere. So maybe we need to think out of the box and find a new way to analyze the neuroretinal rim. So we proposed the minimum distance band, which is the thickness of the neuroretinal rim between the cup and the disc. And the cup surface is seen in black here on the lower right, and then the disc border is the RPE and Brooks membrane seen in red. So with that, other research before have, as well as our group, has shown that maybe these reference plane independent parameters may be better diagnostically for the neuroretinal rim than reference plane dependent parameters. So other researchers include Povazet, who looked at 3 eyes, suggesting that maybe area of the neuroretinal rim is a good parameter. We looked at some other eyes and also found that perhaps thickness over area may be better for correlating between clinical data of disc photos and visual fields. And here you can see in the middle videos a thick blue neuroretinal rim in the video in a normal patient versus a thinner neuroretinal rim in a glaucoma patient. Then in monkey studies by Claude Braque-Goins' group, longitudinal analysis of monkeys showed that also maybe width is better than area, and also in Bao Shahan's group that width may be better than area. So putting all this research together, we have embodied in the Spectralis software the BMO minimum rim width, which is shown here in the yellow band connecting the surface of the cup and the Brooks membrane opening. So the last parameter in the software is the macular parameters. In pre-OCT days, Sanjay Asrani and some other glaucoma did some excellent research with retinal thickness, suggesting that this may be a good parameter for monitoring glaucoma. This, of course, makes sense because the glaucoma affects the ganglion cells, and half of the ganglion cells are in the macular region. And post-OCT days in spectral-domain OCT, Spectralis affords us the posterior pole asymmetry analysis, which is an 8x8 grid of total retinal thickness. You can also segment different layers, such as the ganglion cell thickness maps. However, the UCLA group suggested that this may not provide an added advantage for detection of progression. So most people still look at total retinal thickness with the PPAA analysis. So you can also look at macular thickness or retinal thickness with the ETDRS circles centered over the fovea. So what is clinically significant change for all of these parameters? For the nerve fiber layer, we usually use what's called event-based analysis in the clinic, and this is basically what change do I see on the OCT that is greater than normal test variability and greater than what you'd expect for the normal decline associated with aging. And this being said, this assumes that your OCT data has no testing artifacts. And sadly enough for our glaucoma practice here as glaucoma specialists, the normal OCT retest variability is worse when we need it the most, meaning OCT variability is most for glaucoma patients compared to normal patients, and unfortunately also worse when you look at sectors and quadrants inferiorly and superiorly compared to average values. But for the sake of this talk, we're going to pretend that our OCT data is perfect. So nerve fiber layer progression analysis, what is considered normal retest variability? According to the Spectralis user's manual, it's closer to around 4 microns. Glaucoma patients, a little more than 4 microns. And then reviewing all the literature on reproducibility, the maximum variability is reported to be 4.33 microns. So looking at all this data, I conclude that if my patient's nerve fiber layer thins by 5 microns or more, then more likely this is real disease progression and less likely measurement noise. So what has changed considered from normal aging for the nerve fiber layer? Studies in the user's manual and the literature suggest that it's less than 1 micron per year, which is less than normal intertest variability or measurement noise. So again, I think if we see a change of more than 5 microns, that this again is more likely due to real disease, less likely due to normal aging and reproducibility measurements. So how do we determine change? Well, the Heidelberg machine does give us some change maps, as you can see on the left, and in the middle you can see you can map global RNFL thickness, and on the right you can even map the trends for each sector or quadrant. But sometimes you just have to determine change by looking at the actual numbers. So in the first scan on the top, you see the global RNFL thickness is 80 microns, decreases in the second scan to 76 microns, so this is 4 micron difference, which could still be normal intertest variability. But by the time you get to the third scan, it's down to 72, which is an 8 micron difference, and more likely due to real progression, and less likely due to normal aging changes and intertest variability. And of course, as David mentioned before, once you hit the floor, the nerve fiber layer thickness measurements is not as useful, and for a Spectralis machine, it's around 50 microns. And 50 microns of nerve fiber layer is really this non-neuronal tissue component of glial cells and blood vessels. So once you hit 50 microns, your OCT can quote-unquote ostensibly be stable, but your visual field could be progressing. So for the optic nerve, the BMO minimum rim width, what is the expected change for normal test intertest variability? For normal patients and glaucoma patients, according to the user's manuals, around 7 to 6 microns. Review of the literature suggests that the greatest variability could be up to 12 microns. So my conclusion is that if you see a change of 13 or more, that you can more likely say that this is glaucoma progression of the neuroretinal rim and less likely due to measurement noise. And 13 is an easy number to remember. Of course, we associate 13 with bad luck. So change due to greater normal aging changes. The studies suggest that normal aging changes in neuroretinal rim is less than 2 microns per year, which again is less than normal intertest variability. And therefore, again, we can still safely say if you have a change of 13 microns or more, that that is more likely due to disease progression and not aging or intertest variability. So that being said, the Spectralis software does show us different ways of looking at pattern recognition. So if we see change from baseline, but again, sometimes we just have to look at the actual numbers and see if these numbers are clinically significant. And then lastly, for the macula, what is normal intertest variability? The user's manual says between 2.6 to 4.5. The literature says closer to 3. So again, I think a safe number is 5 microns or more, can be considered clinically significant retinal thickness thinning in the macular region. And again, measurement noise, this is oversimplification, of course, but more likely 5 or more is clinically significant. And then, of course, lastly, due to aging changes, the user's manual suggests that it's less than 1 micron per year, which again is less than intertest variability. So again, 5 microns or more is highly suggestive of glaucoma disease progression. And again, the Heidelberg software gives us some pattern recognition. Here you can see it helps us to focus on the inferior arcuate defect in the right eye, which is greater than the inferior arcuate defect in the left eye. Here's the change map where you can see the red area suggesting possible change in the inferior arcuate region. Here you can see the change map is just purely black, and this suggests no change between the two above scans. And then lastly, of course, you sometimes just have to determine change by looking at the actual numbers. Here's a patient where the superior retinal thickness is 317, then it decreases in the bottom scan to 315, which is only a 2 micron difference. And again, this is more likely intertest variability and not glaucoma disease progression. So a note on trend-based analysis, I think this is more a research tool because I'll show you here, this is a patient where the green line suggests a slope of 0, no progression. And basically for trend-based analysis, we want to see if our patient's nerve fiber layer thickness value is statistically different than a slope of 0. So at the bottom here, you can see at 2.5 years, the patient is supposedly progressing according to trend-based analysis. However, if you add more data at 4 and 5 years, the lower right at 5 years shows that now my patient, same patient, is stable because the line is not statistically different than a slope of 0. So this study underscores that you can have false positive detection of progression with trend-based analysis, and up to 25% of normal patients can be deemed to have progressed when they actually haven't. And so in the big picture, the summary is, when is OCT good? It's good earlier in the disease, when potentially structural changes can occur before functional changes, when there's good reproducibility. And also our group is thinking that spectral domain has not reached its full potential, because there are other parameters that may be more helpful than nerve fiber layer thickness, such as peripapillar retinal thickness, where you can see defects sometimes when nerve fiber layer maps don't show it, peripapillar retinal volume, as well as peripapillar retinal nerve fiber layer volume. When is OCT bad? OCT bad, of course, is later in the disease, when the floor effect has been reached and when the data is not perfect. So in summary, Spectralis has a lot of great information, but this great information should always be correlated with a clinical disease. And as in this example, when the OCT says the patient's normal, when in fact the disc hemorrhage and the visual field says otherwise. So that's my comments on Spectralis and progression.